Hello everyone, welcome to a series on valvular heart disease. In this episode, I am talking about mitral regurgitation. Before getting into the topic, let's see something about mitral valve in general. It is a bicuspid valve, that is with two cusps, and it closes after the atrial systole, that is before the isovolumetric contraction of ventricles. And here you can see mitral valve. It is present between left atrium and left ventricles and prevents the backward flow from left ventricle to atrium. And we see cardiac cycle. Here we see the systole and diastole of ventricles, and then systole which is of 0.3 seconds. It comprises of isovolumetric contraction, rapid ejection and reduced ejection. And then diastole, it is of 0.5 seconds and it comprises of protodiastole, isovolumetric relaxation, rapid filling, reduced filling and atrial systole. And the knowledge of cardiac cycle is necessary to learn about pathophysiology of various valvular heart disease. So it is important to learn this. And then let's get into the topic proper, mitral regurgitation. Here, mitral regurgitation is the backward flow of blood from left ventricle to left atrium during systole, not during diastole. And here it is because of incomplete closure of mitral valve. And in this picture you can see this is the normal flow from left atrium to left ventricle, and the regurgitant flow will be in reverse direction, that is from left ventricle to left atria. And then let's get into etiology. Here the etiology may be primary or secondary. And then primary causes. The primary causes mostly because of leaflet and cordage issues. They may be myxomatous or rheumatic fever, infective endocarditis, healed infective endocarditis, and congenital causes may also leads to mitral regurgitation, and then exposure to radiation. And secondary, here it is because of annular dilation, and the annular dilation is because of LV dysfunction, and here the left leaflets and chordae are not affected, so it is called innocent bystanders. And then various causes are ischemic cardiomyopathy, dilated cardiomyopathy, hypertrophic cardiomyopathy, and atrial fibrillation with left atrial enlargement and annular dilation. And other cause is mitral annular calcification. And then let's get into pathophysiology of mitral regurgitation. Here you can see mitral regurgitation, that is backward flow from left ventricle to left atrium during systole phase. And here you can see during systole the pressure in aorta will be more compared to pressure in left atria. So the flow occurs towards the area with less pressure. So more blood enters into left atrium than aorta, and which leads to volume overload because more blood stays in the heart, and which causes eccentric LV hypertrophy and dilation. The LV hypertrophy is because more blood has to be pushed from the heart because of volume overload, and dilation is because more blood, more dilation. And because of this the ejection fraction will be increased. So in case of mitral regurgitation the ejection fraction is increased, but in case of severe mitral regurgitation the left ventricle fails so that it cannot push more blood, and which causes decreased or normal cardiac output, that is ejection fraction. And here you can see there will be LV eccentric hypertrophy with volume overload. That is, there is hypertrophy, that is increase in the thickness of wall, and dilation. Here you can see increase in the chamber size, and there will be LA enlargement, that is left atrial enlargement. It is because more blood is pushed into the left atrium, so it has increased in the chamber size. And let's get into the clinical features. Here we see clinical features, that is symptoms. And in mild to moderate mitral regurgitation, it is often asymptomatic. It is because the increased ejection fraction is present in mitral regurgitation. But there may be palpitation because of hypertrophy, and then in severe mitral regurgitation, LV fails, as we saw in the pathophysiology, and which causes cardiac output to become decreased. And in severe mitral regurgitation, there may be pulmonary hypertension and right heart failure, and which leads to various symptoms such as exertional dyspnea, fatigue, paroxysmal nocturnal dyspnea, orthopnea, pulmonary edema, painful hepatic congestion, pedal edema, and ascites. And then let's see signs. These are the signs which are normally seen in CVS and valvular heart diseases. Let's see one by one. At first, it's pulse. Here the pulse will be pseudo collapsing, unlike aortic regurgitation in which it is collapsing pulse. And here you can see there will be rapid upstroke and rapid downstroke, but here it is well sustained peak. The peak will be well sustained with high volume. And then blood pressure. Here the blood pressure will be normally present, and but in case of severe mitral regurgitation, it will be low. It is because of decrease in cardiac output. And then jugular venous pressure. Here usually no changes in mild to moderate condition, as right heart involvement is less, but in case of severe, right heart involvement will be present and it may lead to elevation of JVP. And apex, the apex here will be hyperdynamic, that is there will be increased volume due to increased ejection fraction and rapid rising, and it will be longer than usual. Here we see heart sounds. Here the first heart sound produced by closure of mitral valve will be soft. It is because due to the loss of coaptation of valve leaflets. And the second heart sound will be widespread in severe MR. It is because of early closure of aortic valve, and it happens as the blood flows to the less pressure area, that is left atria. The closure of aortic valve will happens earlier. And then S3, here the S3 will be present. It is because more blood present in left atria flows through left ventricle, and which produces a early diastolic sound, which is third heart sound, and S4 will be absent. Then the most important feature is murmur. Here the murmur is pansystolic, that is it is systolic. It's because the backward flow happens only during systole and not during diastole, so it is systolic murmur. And how it is pansystolic? Because the intensity of murmur doesn't change between early, mid and late diastole. Here you can see same intensity throughout the systole. that is between S1 and S2, and it is because there will be uniform flow, and the reason is the regurgitant pressure gradient is maintained throughout the systole, and it will be burst had at the apex and radiate towards the axilla. And these are the other features like pulmonary edema, pleural effusion, parasternal heave, and edema ascites raised JVP. These are because of pulmonary hypertension and right heart failure. And this is a table showing all the signs of mitral regurgitation combined. It will be useful to you. And then diagnosis. Here the diagnosis is by gold standard method, that is transthoracic echocardiography, and then ECG. Here there will be left atrial enlargement and atrial fibrillation may also be seen. And in case of chest X-ray, you can see enlargement of left atrium and left ventricle. And in severe cases, there may be pulmonary congestion also. And the severity in mitral regurgitation is by 60-40 rule. You should remember this. And here the 60 is left ventricular ejection fraction. If it is less than or equal to 60, it is considered as severe, because in mild to moderate the ejection fraction will be increased. So if it is normal or decreased, it is considered as severe. And if the left ventricular end systolic dimension is more than or equal to 40 millimeter, it is considered as severe. And here we see management. Here the medical management is only for supportive, and medical management is by AC inhibitors, beta blockers, and anticoagulants. Here the anticoagulants may be used to prevent thrombi because of atrial fibrillation and LA enlargement. And AC inhibitors and beta blockers, it is because in case of mitral regurgitation, if the systemic blood pressure increases, the more blood will enter into left atrium, because we saw in the pathophysiology in aorta there is more pressure, and left atrium there is less pressure, so blood enters in more into less pressure area. So we have to control the blood pressure here. In acute cases, these are most important to decrease the blood pressure. And then the surgical management. Here the repair of valve is preferred over replacement of valve. And then these are the indications like symptomatic mitral regurgitation and 60-40 rule. That is, these are the things present in severe mitral regurgitation. So surgery is recommended in all severe mitral regurgitation cases. And do like, share and subscribe my channel. Thank you.